Check, check, check. No video. Okay. السلام عليكم ورحمة الله، وأسعد الله مساءكم بكل خير، وأهلا ومرحبا وأهلا وسهلا بكم جميعا في SAPH 2023. أهلا وسهلا بكم اللي جو من بعيد واللي من قريب. فأهلا بكم. وأفضل من يقدم لهذا المؤتمر our captain الأستاذ الدكتور عبد الله الضلعان. He is the chairman of this conference and the chairman of Saudi Association for Pulmonary Hypertension. Dr. Abdullah, I worked with him since the last conference until today, and we spent so many hours planning for this. And I learned so many things from him, his attention to fine details. And despite he is being so busy with his own work, he always made himself available to answer questions and to give direction. Professor Abdullah, without overdue, please. Thank you. Welcome, everyone.
Thank you so much, Abu Saleh. Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to SAPH 2023. This is our 16th annual meeting for pulmonary hypertension. We are all proud that SAPH is a dedicated society for pulmonary hypertension. It's actually the only standalone society dedicated for pulmonary hypertension in the region. And we have been holding many annual meetings. This is our 16th, but we also do a series of small educational meetings throughout the country for the last 16 years or so. As it has been the custom, the first night is normally a welcome night and an opening ceremony, and many people are normally coming from different parts of the world and from the country. So the first night is only a reception ceremony and dedicated to 30-minute long talks. One is normally a keynote speech, and each year we give it to one of our colleagues from international experts in the field of pulmonary hypertension. And the other one is normally a PH, a clinical year review for the studies that have been published for PH in the last year. This is the first session tonight. This year, however, we made a little bit of different approach. This year we brought a patient who is going to share his experience with you. He's our real life patient from King Faisal Hospital, Mr. Fahad Al-Qahtani. At the end of the session, you will hear firsthand about the experience of patient of pulmonary hypertension. He is actually a SAPH patient, not a PH patient. And then tomorrow, normally we start with a basic science research update session. And we always encourage a local data. This year also, we had a last minute call from UK, a Saudi PH student who is going to also, we added her at the end of the session. Probably it's not reflected in your program, but we gave her 5 to 10 minutes to speak about her work. And then obviously we will do different sessions over the coming 2 days, covering almost all aspects of pulmonary hypertension, but also centered around the updated ERS ESA ESC guide 2022 guidelines, which is probably, as you know, fresh and need to be focused on this year. So this is roughly the program. I have to extend my thanks to the head of the scientific committee and his colleagues, Dr. Shaya Shaya, who all came up with a comprehensive program, and I'm hoping you will enjoy over the coming 2 days. Let me first thank our colleagues who came all the way from Europe and United States to share their experience with us. Thanks also our colleagues who are regional or local from the country, the chairs as well. And of course, I have to thank the pharmaceutical supporter for us. Without their support, the whole SAPH has not been an entity for the last several years. I have to name, however, the main two supporters for SAF, Janssen and Bayer, have been always a great support to us. Of course, the other supporter, Pharma Science and other groups, are always been with us all the time. Thank you also for the individual support, and many thanks also on my behalf and on your behalf to Hassan Al Araini, the executive administrator director of SAF. He is basically the organizer for this program and all SAFs for the last several years. A few logistic notes. Tonight we will have, after the patient experience session, we will have our dinner in the same hall where we had the exciting, by the way, an exciting and very fruitful workshop today, and the exhibition in the hall beside us here, and the breaks, the coffee breaks, will be there as well. And tomorrow, at the end of the session, the end of the day, we will have our dinner and a little tour before that in Ithra building, the King Abdulaziz Cultural Building, where there will be some tour, and then we'll be holding our dinner there as well. These are the most important things, and let me now call my colleagues, the chairs for this session. Let me start with my colleague and friend, Professor Majdi Idris. He is the founder of SAPH, and he is a PH expert in the country. He is a consultant pulmonologist in the military hospital. Majdi, please, the place is yours. And then Dr. Shaya Al-Shaya, he's a consultant pulmonologist at King Fahd Medical City. Shaya is the head of the scientific committee this year. Him and his colleague came up with a very nice program. They will be chairing the session, and then they will be also introducing our two main speakers for tonight. Thank you, Majdi, and thank you, Shaya, and welcome all to SAPH 2023.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Professor Abdullah, for this nice introduction to the whole program. It's always so exciting to be here in SAPH. You all know about the story of SAPH, and Dr. Abdullah is the really representative of how SAPH really ended. So welcome to SAPH. So without further ado, my name is Majdi Idris. I'm a consultant pulmonologist from Riyadh. I'm co-chairing this session with my dear colleague, Dr. Shaya, who will be introducing the first speaker.
So thank you so much, Professor Majdi. Actually, I'm really honored to share with you this session. So this is the first session in SAPH 2023. So pulmonary hypertension lecture. First lecture will be talk about prostacyclin from the first to the last and backward. So prostacyclin is the most potent pulmonary hypertension targeted therapy and the first to start and introduced in pulmonary hypertension field. So actually, it's my honor to introduce the Professor Oliver Sitbon. He is a professor of respiratory medicine and pulmonary hypertension reference center in Pasteur Hospital, Paris, University, France. So Professor Sitbon, the floor is yours.
Thank you very much for your kind introduction, and salam alaikum, and and thank you again, Abdallah, for your very kind invitation as usual. And it's a real pleasure to be here after many years, and it's always a real pleasure. Thank you. So you asked me to cover the to cover the topic of the prostacyclin from the first to the last therapeutic option and backward. We will discuss about this at the very end, and probably this will be maybe more open for discussion. So that's my disclosures. If you start with the rationale, so why to use prostacyclin in pulmonary arterial hypertension? You know that prostacyclin is an endogenous substance produced by the endothelial cells. It is a very potent vasodilator, and also it can limits the platelet aggregation, and also prostacyclin has anti-proliferative effect. And there are some rationale to use the drug in PAH because we know that in PAH there is an imbalance in between the production of arachidonic acid metabolites with a decrease in the metabolites of prostacyclin and an increase in the metabolites of thromboxane. And also we also know that in the pulmonary arteries of patients with PAH, there is a reduced expression of the prostacyclin synthase. Here it's a schematic representation of the different mechanism of action of the prostacyclin receptors. And we know that the prostanoid IP receptor is binded by the prostanoid, and it induced the adenylate cyclase activity, the CIMP production, and finally the reduction of the small muscle cell calcium concentration, and finally vasodilatation. And the other receptors are less important, but we have also to mention the TP and the EP3 receptor that can, contrary to the IP, that can block vasodilation. There are many drugs targeting the prostacyclin pathway in PAH, and it is I like this picture coming from a review by Irene Lang and Sean Gain, published in the European Respiratory Review. And you have some route of administration: inhaled, oral administration, intravenous administration, and finally subcutaneous administration, or also implantable pump for IV administration. And there are some studies, and we will review with you all the studies that have been published with those drugs. Let's start with parenteral prostacyclin. And this is a very ancient slide. It's a quarter-century-old vintage slide when we did this kind of slide in the blue and yellow. And this is a representation of the first use of prostacyclin in a single patient. It was reported in the Lancet by Tim Higginbotham in 1984, almost 40 years ago. And as you can see, you can see here, where is it's here. These patients was responding acutely also to epoprostenol with a fall in PVR acutely, and this was maintained on the long term. And then we had the first randomized controlled trial published by Robin Barth in 1996 in the New England Journal of Medicine, showing that the chronic treatment, the 12-week treatment with epoprostenol, intravenous epoprostenol, may improve survival. And in that study, 8 patients died while they received conventional therapy, as compared to no patient who died while they received intravenous epoprostenol. And then we published a few years later with the group of Chicago, with Val McLaughlin and the group of our hospital in France, very, very similar results regarding the use of long-term epoprostenol in clinical practice. And we've observed a 63% survival at 3 years in both studies. It was much better than it was in the past. What about the subcutaneous treprostinil when used in monotherapy? And we know that the first study was the first randomized controlled trial published by Gerald Simoneau, my mentor, in 2002. And it was the first randomized controlled trial with that drug, showing a modest improvement in 6-minute walk distance. However, this was highly significant. We also observed hemodynamic improvement, but no effect on outcome, on survival, but it was a short-term study. Then in particular in the US, they published the long-term results with subcutaneous prostacyclin, subcutaneous treprostinil, and you have here the overall survival. It was 71% survival at 3 years, but also there are some problems we can observe with subcutaneous treprostinil that patients who discontinue the drug due to side effects. And as you can see here, this is the rate of discontinuation, which was something like 30% after 3 years. In the more recent years, the survival was broadly the same. And if you look at this, this is the French experience with epoprostenol in the French network. And as you can see, the survival in the more recent years, it was only 69% at 3 years. However, when we observe differences in between patients receiving initial therapy with epoprostenol and patients who receive epoprostenol as an add-on therapy, we observed important difference in terms of outcome in favor of initial therapy with epoprostenol, and those patients had a much better survival. That's why in the previous guidelines, not that one, but the previous guidelines, that was the recommendation for the use of prostacyclin, of intravenous epoprostenol, intravenous iloprost, or intravenous treprostinil. And as you can see, it's particularly true for intravenous epoprostenol, there was a very strong recommendation in both patients in class 3 or in patients in class 4. However, despite this recommendation, the use or the parenteral prostacyclin are underused in patients with severe pulmonary arterial hypertension, and this is the data from the REVEAL registry showing that the patients, the treatment received by the patient at the time of death or within the 6 months before the death, and about one half of the patients were not receiving parenteral prostacyclin just before the death. In other words, you can say that about 50% of patients received, which is quite good. And we recently look at what happened today in the French registry and in the UK registry. We observed that only 16% of the patients receive intravenous prostacyclin at the time of death. However, when we treat patients with intravenous epoprostenol or subcutaneous treprostinil, we don't have to wait too much. And it's much better to start the treatment when patients are in functional class 3 as compared for the patient in functional class 4. And it is particularly true also in patients while on background therapy. This is the patients who receive bosentan as a background therapy, and that the survival of patients initiated with prostacyclin while they were in functional class 3. And this is the survival of the patients receiving prostacyclin when they were in functional class 4 at the time of initiation of prostacyclin, and we observed huge differences. This is also the data of the use of intravenous treprostinil as an add-on therapy in patients who receive oral drugs or other drugs. And this is the transplant-free survival of the patients according to the risk status achieved after treatment escalation. And as you can see, only 19% of the patients were reclassified as at low risk after treatment escalation with intravenous treprostinil. Only about 20% of those patients. And those patients, they have a very good long-term outcomes and survival. For the other patients, as you can see, the survival was very poor. It's probably because the treatment was initiated too late, and this is one explanation for that. So why not to use initial combination therapy with prostacyclin? And the first attempt was the BREEZE-2 trial. The BREEZE-2 trial was the initiation of epoprostenol plus bosentan as compared to epoprostenol plus placebo. It was the first attempt of initial double combination therapy It was a short-term trial including only 33 patients, and as you can see, the, the, there was the primary endpoint was a change in TPR, and this was not significant when we compare the two treatment groups. However, we have much more patients who achieve a better hemodynamics with the double combination therapy as compared to patients receive only monotherapy. It was not significant, but the study was underpowered. And in France, we continue with this because we believe in this strategy. And with Krista Kent, a few years late after this, we published the data of our experience in France, and we observed that maybe there was it was a trend to a better survival in patients receiving initial combination of epoprostenol and bosentan as compared to patients receiving only epoprostenol monotherapy. And then we move forward and we considered triple combination therapy in very, very selected patients, young patients with idiopathic or heritable PAH. Those patients, the mean age was 39 years, but they were very, very severe. The majority of them at baseline were in functional class 4, and some of them were in functional class 3. But as you can see, the hemodynamics was very, very, showed a very, very severe pulmonary arterial hypertension with a mean PP of 65, cardiac index 1.6, PVR about 1800 nines. And as you can see, as early as after 4 months, we observed a dramatic improvement in symptoms. This is a functional class. All but one patient were reclassified as functional class 1 or 2, and this was sustained. And we also observed a very, very nice hemodynamic improvement with a fall in PVR by 20 millimeter of mercury in average, and also decrease in of mean PAP, and decrease in fall in PVR by about 70% after 4 months, and this was also sustained. And this was repeated with sub-Q treprostinil. It is a data published by Michele Dalto in Chest 3 years ago, repeating exactly the same result that we observed with intravenous epoprostenol. And it was a combination of sub-Q treprostinil plus ambrisentan plus tadalafil. And as you can see, minus 69% decrease in PVR. Almost all patients reclassified as low risk, and also observed improvement in echo parameters. And 2 years ago, we published with Athénaïs Boucli the data of the French PH registry, and we look at the association between the initial treatment strategy and the long-term survival. And we analyzed the data of more than 1,600 patients initiated with the PH therapy, majority on monotherapy, 1/3 on dual combination, and only 5% on triple combination. And we look at the survival, and we look also at the effect. We look at the clinical effect, and this is the number of low risk status of the low risk criteria, present at baseline here and achieved at follow-up. And look at the triple combination therapy. At the triple combination therapy group, all patients, they don't have any or just one low risk criteria present at baseline. And if you look at the first follow-up, we have 80% of the patients achieving 3 or 4 low risk criteria. We observe a dramatic improvement in symptoms, in exercise capacity, and in NT-proBNP. And finally, when we look at the survival, we observe that we did not observe any differences in between mono and double combination, but only the patient receiving initial triple combination had a very nice survival. And when we did a propensity score to match the patient on age, sex, and PVR, because those patients were younger, but they were also more severe. And despite when we match those patients with the propensity, we observed a very, very similar difference between triple and double combination. And also for the patient at high risk, it was obvious, but also in patient at intermediate risk, we observed a much better improvement in survival in patient on triple. And finally, when we look just at the survival in patients receiving intravenous or subcu prostacyclin in each arm, triple, double, or mono, we observe very, very similar results in favor of triple combination. So that's why the recent guidelines considered that for the patients who present at high risk of death, an initial combination therapy with a PD-5 inhibitor plus an endothelin receptor antagonist plus IV or subcu prostacyclin analogs should be considered with a quite good class of recommendations. Sorry for that. With a quite good class of recommendation 2A, but with the level of evidence of C because we do not have any randomized controlled trial. So regarding there are some issues, of course, with the parenteral prostacyclin, and the typical prostacyclin adverse events are jaw pain, extremity pain, flushing, headache, etc., diarrhea, nausea, etc. And when we analyze more in detail the IV delivery problems we have, this is mainly due to bloodstream infection and sepsis. It's not so frequent, but it can this can cause some problem in patient receiving the drugs because we have to remove the catheter, etc. And regarding the subQ, we have local side effects, and in particular infusion site pain, which can occur in about all patients, and this may lead to treatment discontinuation or preclude increase in dosage. And you have some example here. So that's why there are some attempts to develop different mode of administration for prostacyclin. First one was inhaled iloprost, sorry, was tested first in a randomized controlled trial, the AIR trial, including more than 200 patients. And in the AIR trial, there was, for the first time, we used a component endpoint, a multi-component improvement endpoint, including improvement in 6-minute walk distance of more than 10%, plus improvement of the functional class by at least one class. And this is the combined. This 17% of the patients achieve the endpoint with inhaled iloprost as compared to only 5% with the placebo. And this is the system for inhalation, which was quite complicated and quite cumbersome. However, when we look at in the experience in the real world, the survival with inhaled iloprost was not so good. And as you can see here, for example, the survival at 2 years was only 25%. So probably this drug given as monotherapy is not efficient enough to improve outcomes of patients. There are two studies using inhaled iloprost on background bosentan, the COMBI trial and the STEP. Both were negative, and it was almost positive maybe for the STEP with an improvement in 6-minute walk distance, but it was almost significant. The P was 0.051. And in contrary, the COMBI trial was totally negative. And finally, the recommendation by the guidelines was the addition of inhaled iloprost to bosentan may be considered to improve exercise capacity with a quite weaker recommendation 2B. Inhaled treprostinil, which is another prostacyclin given by inhalation, there is only one study. Once it was the TRIUMPH randomized controlled trial, including 235 patients. And again, you have an improvement, modest improvement in the 6-minute walk distance and the recommendation is the addition of N-treprostinil to sildenafil or bosentan, because all those patients were on monotherapy, should be considered to improve exercise capacity. The recommendation is a bit better, 2A, but it was not the best one. What about oral prostacyclin and prostacyclin receptor analogs? There are some attempts with the beraprost giving some controversial results. In the Alphabet study, the study was positive. In the longer US study, the study was negative. And then the oral treprostinil was developed, and it was tested first as a combination therapy on top of either endothelin receptor antagonist or PDE5 inhibitor, or sometimes both. But those two studies were negative, and there was one positive study, but very marginally positive, which was the Freedom M oral treprostinil given as monotherapy. And more recently, there was the Freedom EV, which was an event-driven long-term randomized control trial of oral treprostinil on background PAH monotherapy. And as you can see, we had the oral treprostinil reduce the risk of the primary outcome composite of death or morbidity due to PAH. And however, due to side effects, the rate of discontinuation was much important with oral treprostinil as compared to placebo. So the recommendation in the guidelines is the addition of oral treprostinil to monotherapy with an array or a PDE5 inhibitor is recommended to reduce the risk of morbid mortality event, and the recommendation is quite good. 1B, because we just have one trial. Finally, on the non-personate IP receptor agonist, and the first developed was selexipag, and selexipag has a high affinity and selectivity for the IP receptor. It was tested first in a phase 2 trial, showing a significant decrease in PVR as compared to placebo, with the treatment effect of -33%. And recently, there was also another phase 2 study with ralinepag, which is an immediate release oral non-prostanoid IP receptor agonist. And again, the primary endpoint was a change in PVR. It was positive in favor of ralinepag as compared to placebo, and this is the change in NT-proBNP level. And there are two phase 3 ongoing studies with ralinepag. Griffon was the phase 3 trial with selexipag, and in Griffon, selexipag reduced the risk of the primary outcome composite of death or morbidity due to PAH, with a reduction by about 40%. And this was driven by hospitalization for PAH worsening and disease progression. Finally, the recommendation of the guideline is the addition of selexipag to endothelin receptor antagonists and or PDE5 inhibitors is recommended to reduce the risk of morbidity mortality events, with a class of recommendation of 1 and the level of evidence of B, because we just have one trial. Then, to finish, I would like just to mention the Triton trial. The Triton trial, it was the strategy trial of initial triple combination with selexipag plus macitentan plus tadalafil compared to macitentan plus tadalafil plus placebo. And the study, 250, almost 247 patients have been included in that study. However, the study was negative. We did not observe any difference in between the change in PVR. It was good, -54% with triple, -52% with double, exactly the same for 6-minute walk, exactly the same for NT-proBNP. Maybe there was a mild improvement in disease progression with triple as compared to double, but this was pure exploratory analysis. So finally, in the guidelines, the initial combination of therapy with macitentan, tadalafil, and selexipag is not recommended. And this is the algorithm of the guidelines. In the algorithm from the guidelines, where to find prostacyclin and prostacyclin analogs, we found here, here, and here. Here, for the patient at high risk, at the time of diagnosis, we have to consider triple combination therapy, including IV or sub-Q prostacyclin. In patients who remain at intermediate low risk after the first reevaluation on therapy, we have to consider addition of a prostacyclin receptor agonist here. And for the patient at intermediate high or high risk, at that time, we have to consider addition of IV or sub-Q prostacyclin and or evaluation for lung transplantation, of course. And this was mentioned in this table. And we would like to finish with what about backwards, because you asked me about that. And I just have one slide for that, because it's very, very difficult to provide strong recommendation. I don't want to provide strong recommendation because I think it could be very hazardous to consider de-escalation in patient on IV or sub-Q prostacyclin. The evidence is weak. There are some case reports that are very, very anecdotal and small series of transition from IV to sub-Q or inhaled to oral therapy. Very few. I don't want to go into too much detail. And finally, the transition from parenteral prostacyclin to another drug, oral prostacyclin or others, should be considered with caution in very, very selected patients. Very, very selected patients. I just want to mention some idea about what is a very selected patient that could be transitioned safely, patient at least at low risk, functional class 1, 2, no symptoms, good walk test, normal BNP and NT-proBNP, normal RV function, and major hemodynamic improvement, in particular, decrease in mean PAP. I can suggest less than 30, but there is no evidence for that. PVR less than 3 to 4. And in all cases, we have to consider a close monitoring of those patients after transition. Thank you very much for your attention.
Thank you so much, Olivier. This was fascinating revision of the topic. So I think we have 2-3 minutes. So maybe we can allow for 1 or 2 questions. Maybe I can start. Then, Olivier, very nice data showing that initial triple therapy with IV prostacyclin or really parenteral prostacyclin make a lot of difference compared to the double oral combination. But what about compared to triple oral combination? I mean, you have to start with basically 2 oral plus IV prostacyclin versus triple oral. Do you think this would make a difference in those cases?
We have indirect comparison because we know that initial triple oral combination is not better than initial double oral combination. It is the result of the Triton trial. We don't have direct comparison in between parenteral prostacyclin oral drugs as initial therapy, but I'm pretty sure that we don't need this kind of study because we already know that initial triple oral is not better than initial double. So why to compare with triple? I think initial triple with IV or with sub-Q is totally different. Why? I don't know, because probably all the drugs are not the same. And oral prostacyclin, oral treprostinil, or selexipag, and inhaled drugs, or IV or sub-Q drugs, they are not the same drugs. Not the same molecule sometimes, not the same mode of administration. And this probably makes the difference.
I have one question from the audience there, please go ahead.
Thank you, Professor Sitbon. A really great talk. I really enjoyed it. So my question about the underuse of prostacyclin, the IV prostacyclin. It's really surprising that quite a number of patients started late on the disease 6 months prior to death. So from your experience, what are the reasons behind that? Is it delay from the patients or the physicians?
I think first of all the PH population has changed in the past. When we compare to the 30 years ago or 20 years ago, in the past we had just young females with idiopathic or heritable PAH, and in my center it was like that. So it got quite easy to convince them that to give prostacyclin. First of all, also because it was the only drugs available at that time, but it was quite easy. Now, I think we are very aggressive with the young patients, and we continue to give intravenous drugs initially, for example, to a patient with heritable PAH, and but we also have more and more an older population with comorbidities, and honestly, it's really very difficult to consider initiation of IV drug in a patient 75 or 80 with diabetes, with hypertension, obesity, and what you want. And so I think the population markedly changed, and this impact, of course, of the rate of patient receiving the drug.
And it will be very short, please.
Thank you, Olivier, for the talk. And I think I just wanted to say something to fulfill Dr. Abdullah's vision for this particular talk. Why not start with aggressive upfront parenteral prostacyclin therapy as we started 25 years ago? I think this is the whole notion. Now, even the guidelines are pushing for earlier start. We have seen it clinically. Whenever we delay aggressive therapy, bad outcomes happen. And we have seen enough data, yours included, that when you start early enough, aggressive enough, you have an excellent survival.
No, you're right. I think we are now we have more and more drugs and more drug easy to use, and for the majority of the specialists, we consider that we have to start with the initial combination of oral drugs. But I agree with you. Sometimes it's not enough, and we have to do more. And but there are some reluctancies amongst doctors, amongst patients. Patients know more and more the disease. They know the options, and sometimes it's more and more difficult. But we can go maybe to very aggressive initial therapy, and maybe to have a kind of a transition to much easier drugs for the patient who succeed with the initial treatment. But it could be proven in the next stage.
Thank you so much, Olivier. This was fascinating. So we're going to move now to the next talk. It's my great pleasure and honor to introduce my friend, Professor Luke Howard. Professor Howard is a really expert in pulmonary hypertension. He's a consultant pulmonologist from Hammersmith Hospital, basically Imperial College, London, UK. He is and he's a very dynamic speaker. I need to say that, and I'm sure you're going to enjoy his talk talking about PH Year in Review 2022. Luke,
Thank you very much. I hope you didn't notice Olivier's name next to my face. I mean, that's just sacrilege, that is. Look, thank you so much to the organisers for inviting me back. I think being invited back again is always much more of an honour than being invited the first time, so thank you. And I won't risk my Arabic, I'll just say peace be with you. And I think that's a wonderful way to start a talk. And I really commend you all for your great hospitality and welcome. Thank you. So I gave the talk last year, which was Year in Review 2021. So the first slide only I had to change by 1 digit, which is nice and easy. And my criteria for this are papers that were published online in 2022. So if they came in print 2022, but online 2021, I presented them last year. So in case you think I missed something really important, that's probably the reason why. These are my declarations of interest. And I feel this talk is a little bit like, I tried to find one of those pictures where people run on logs across rivers. This is more running across stepping stones. So get ready for quick changes of direction, running across, almost falling over, but trying to get across a lot of stepping stones very quickly to the end. Now, of course, who could ignore the fact that in 2022, the European guidelines were published? Of course, when the guidelines are published, they're immediately out of date. And so anything else that was published around the time may feed into the next guidelines. But I still think that looking at these, they provide an excellent and modern, up-to-date practice. So the first area I'm going to focus on is diagnosis. Now, of course, unless you had your head in the sand, and there's rather a lot of it around here, so maybe that's easier to do than it is in my country, you wouldn't have missed the fact that the definition of pH has changed drastically from a pressure of 25 down to 20, with keeping the wedge pressure the same as 15 and dropping the pulmonary vascular resistance from 3 down to 2. Now, the question, therefore, is, do the ECHO guidelines, which have only changed marginally from 2015 to 2022, still pick up pulmonary hypertension appropriately? And so there are lots of features on ECHO. Oh, okay. It's back. There are lots of features on ECHO, obviously, that can be looked at. The most direct measurement is the measurement of tricuspid regurgitant velocity. And of course, there are other surrogate measurements after that. And so these are the 2022 guidelines. They're very similar, except for the addition of the TAPSI ratio, thanks to the Italians for giving us that shortened way of referring to it. But otherwise, they're all the same. And just to remind you, what we do is the first thing we look at the TR jet, which is a sort of an estimate of pulmonary artery pressure through the right ventricular pressure. And then if that's low, then we look for other of these echo features. Now, what the Italians did and published this in 2022 is looked at the 2015 guidelines and looked to see if they would predict accurately pulmonary hypertension at the old definition and the new definition. But of course, the new definition is what we're interested in. And so first of all, looking just to see if you could predict patients with a mean pulmonary artery pressure greater than 20. And in a multivariate analysis, the only thing that came out was the TR jet. So all of these things, when you've added them in and considered a multivariate model, didn't add anything to the model. Of course, by themselves, they're all extremely relevant. But if we're trying to pick out pre-capillary pulmonary hypertension, so MPAP greater than 20 and a PVR greater than 2, then the multivariate model shows some interesting features. So if you've got a TR jet that's modestly elevated, 2.9 to 3.4, then you also can benefit from looking at other measurements, such as whether the septum is flattened between the LV and the RV, whether there is a shortened acceleration time or notching, on whether there is, what's the last one here? Yes, a distended IVC indicative of increased right atrial pressure. And so when you look to try and predict patients with precapillary pulmonary hypertension, then what you find is that with a peak TR velocity, if you add one indirect sign, peak TRV greater than 2.9, and one indirect sign, your area under the curve improves slightly, your sensitivity doesn't change very much, but your specificity increases. So TRV greater than 2.9 and one indirect sign is a good indication for going on to right heart catheterization. If your peak TR velocity is greater than 3, that's pretty much all you need. So what does this tell us, really? The conclusions from this paper were that the echo prediction strategy of pH defined in the original 2015 guidelines, and now the 2022 guidelines with the addition of TAPSI-PAPSI, is still valid also for picking out those patients with the lower pressures and the new definition of pH, which I think is kind of reassuring. And if you're wanting to pick out patients with precapillary disease with a high PVR of greater than 3 or 2, then you can use the same combination of measurements, but you need this greater sensitivity and specificity when you're taking into account the indirect measurements. So one other topic on diagnosis is at the right heart catheter. So when we have patients with a slightly indistinct diagnosis, then sometimes provocation can be helpful. So we, in this study, they looked at patients and undertook this protocol. So patients were resting, then they had a passive leg raise, which is effectively like a volume challenge, exercised them for 2 minutes, stages at 20, 40, and 60 watts, recovered them, and then gave them a 500 ml bolus of fluid. Now, what they found and what we've got here is the right atrial pressure, the mean pulmonary artery pressure, and the wedge pressure. And with a passive leg raise, you're getting fairly similar increases in all of these as compared with a 500 ml fluid challenge. So, you could argue that's a lot easier to do. But on exercise, you're seeing greater changes in all of these 3 measurements. What does that mean in practical terms? Well, I don't want to get into exercise pulmonary hypertension because I don't really know what that entity is. I think what's important is whether patients are reclassified as post-capillary pulmonary hypertension. And so what you find here is that with a passive leg raise, then with a fluid bolus, and then with exercise, you're reclassifying your patients from pre-capillary to post-capillary. And I think this still leads to a significant area of uncertainty. What does it mean in terms of in practical terms? Potentially a difference in between giving treatment and not giving treatment, or possibly giving treatment more cautiously. So I think it tells us that we do need to be a little bit more attentive to these finer details during cardiac catheterization. New treatments in PAH. Well, 2022 was a little bit quieter than 2021. This old chestnut keeps coming back, and it usually comes from the Chinese. We had a go at this a couple of years ago in a phase 1 trial and found a small difference. But what it was really missing was a sham arm. And so it's nice to see now that there is a sham arm for pulmonary artery denervation. The denervation catheter goes in and they make all the sort of appropriate noises about press the button now, oh yes, it's going on. But of course, the patient will know the difference between being denervated and not because it's very painful. But anyway, at least a sham arm was attempted. And so this was the design of the study. Roughly 60 patients in each arm were given denervation or sham and then given a PD5 at diagnosis. And there were fairly big differences in terms of the outcomes, but in terms of 6-minute walk, NT-proBNP and pulmonary vascular resistance, and also the exploratory analysis of clinical worsening. So I think this story still rolls on, but we need to see this potentially being done in wider geographical areas. So Sotatercept, I spent a bit of time talking about this last year. We all know that the Stellar study has been on press release, was positive, but we haven't seen anything in actual print as yet, unless I've somehow missed it. So that will be for next year. But what I did want to present was the open label extension data from the Pulsar study. And so in this, patients who were on placebo for the original period of 6 months were then transitioned over to open label Sotatercept 0.3 or 0.7 milligrams. In fact, I can't remember if the dose was open label or not, but they knew they were on drug. And not particularly surprising results, but those who crossed over from placebo improved their pulmonary vascular resistance, and those who were originally on Sotatercept maintained their drop in pulmonary vascular resistance. The same thing happened in 6-minute walk, improved in those who crossed over from placebo and maintained in those who were previously on Sotatercept. we see exactly the same things when we look at NT-proBNP, and also then what's kind of interesting is functional class. And so what you see in those crossed over from placebo is an improvement in functional class. So the darker colors going away is good. There's a move over, but there's also a significant, well, I say significant, there's a move in patients who were originally on sotatercept, kind of illustrating the problems with functional class assessment, really. I think once you know you're on open label, maybe the functional class can be influenced by that to some degree. Now, what about SAPH? This is possibly a slightly odd one to put in. This was impacted by COVID. This was a catheter-directed thrombolysis versus anticoagulation study, which was terminated early because of recruitment issues. And the reason I put this up was to look at the long-term outcomes in terms of prevention of SAPH. Now, it's always going to be very difficult because the rates of SAPH following pulmonary embolism are so low. But I think that a lot of people still think that thrombolizing patients potentially can benefit, but the evidence isn't really out there. So nearly 100 patients were randomized to catheter-directed thrombolysis versus anticoagulation alone. I think these patients are quite sick. If you look at, you probably can't see right down at the bottom there, the troponins were significantly elevated. The NT-proBNPs were nearly 2,000. So I think this is a fairly sick group of patients. There were no significant findings in terms of the primary endpoint. P is 0.024 for the 3-month echocardiographic RV-LV ratio. But there are some signals here that are potentially tantalizing. I'm not so interested by what happens at 72 hours, but at 3 months, in terms of unrecovered right ventricular function, we are seeing potentially there could be benefits in the catheter-directed thrombolysis group and also in all-cause mortality. So we still don't really have an answer there for that, and not sure what the plans are in terms of whether that's going to be redone or not in that particular group. But of course there is there's high PTHO that's ongoing, so other studies may come out and give us the answer. Then there were 2 balloon pulmonary angioplasty studies in SAPH. There was the French study and the Japanese study that were published, I think if I go back, August the 1st, 2022. So both published side by side. So this is the study designs were very similar. The French on the left and the Japanese on the right. So you had about 100 patients in the French study and 60 patients in the Japanese study. And in terms of the French data and the Japanese data, fairly similar. A greater drop in pulmonary vascular resistance with balloon pulmonary angioplasty versus riociguat, but similar increases in walk distance, which is interesting, and I think potentially an interesting topic of discussion as to why that might be. But other things that are particularly of note were that in the patients who received balloon pulmonary angioplasty in the French study, and you'll see also in the Japanese study, there were very significant drops in pulmonary artery pressure. Because what tended to happen here is there was a drop in pulmonary vascular resistance, but the cardiac output increase was less so, whereas in the riociguat group, the pulmonary vascular resistance drop was less, but there was a greater increase in cardiac output. So you found less of an impact on pressure with riociguat than you did with balloon pulmonary angioplasty. And a greater reduction in right atrial pressure with BPA. So suggesting, I think, that the right ventricle, is happy, even though the cardiac output doesn't increase as much. The right ventricle in itself is responding more naturally to a drop in vascular resistance. With the Japanese study, you see similar things in terms of a drop in pulmonary artery pressure. One thing to note is that the mean PA pressures are about 10 millimeters of mercury lower than the French. So these patients aren't as severe in terms of their hemodynamics, but you see this significant drop in pressure and the pulmonary vascular resistance with a greater drop in the BPA group. And here with the cardiac index or the cardiac output down here, the riociguat results in possibly a greater rise in cardiac output than BPA. So there may be potentially effects on the myocardium, or it may be a drop in systemic vascular resistance that's causing that. And the same thing with right atrial pressure dropping in BPA, but not with riociguat. So really nice to see those parallel studies coming through showing the same thing. Out group 3. Oh, I've got a frog in my throat. Sorry, that's no reference to the French. He's shaking his head. So inhaled treprostinil. So last year I showed you the results of the INCREASE study, which was showing the primary endpoint of an increase in 6-minute walk distance over 16 weeks. And what this post hoc analysis looked at was whether or not, if you got onto a greater dose of inhaled treprostinil, whether that had greater impacts on I think one thing that's really interesting here, perhaps the most interesting thing, is this distribution. You've got inhaled treprostinil on the left and placebo on the right. And the distributions by eye look roughly the same. You'd think, wouldn't you, that with placebo, everybody would scale up to the maximum dose, but it's quite interesting to see that they're roughly the same. What this graph shows is the rates of clinical improvement versus clinical worsening. And you've got placebo on the left, you've got the outcomes defined by what dose they were on at week 4. And on the right, you've got the outcomes defined by what diagnosis, what dose they were on at the end of the study. So they're showing roughly similar things. You've got placebo, then the next graph, next bar is inhaled treprostinil doses less than 9, and then the one on the right is greater than or equal to 9. And what you're seeing, I think, if we look at the far right one, which is, of course, the what the patients get to in the end, is that the patients who managed to get up to the higher doses had greater clinical improvement and less clinical worsening than the lower doses and placebo, suggesting a dose response curve. So perhaps if we can get more flexible in terms of how we upscale patients outside the context of a rigid clinical trial, we might then get more benefit. And who knows, there may be even benefit beyond the top level, which is on the label. And then the final section relates to phenotypes. And this starts to come out in the guidelines at this point here in the treatment algorithm. You have patients without cardiopulmonary comorbidities, and Olivier talked about this pathway here. And then you have patients with cardiopulmonary comorbidities. And this was the new aspect, really, that I think was very important that came out in 2022. There are going to be more talks on this coming up, so I'm not going to go into great detail. But I permitted myself one slide from 2020 just to put the context here. And what are we talking about with comorbidities? Well, there's 3 types of IPAH cluster, effectively. There's the classic IPAH, which would be the sort of the younger, age 45 females with very little cardiovascular complications. Then we've got the left heart phenotype, which tends to be older, predominantly females, never smokers with lots of cardiovascular issues. And then finally, the lung phenotype, which tends to be predominantly male, older, and smokers with a low gas diffusion. And I've also cheated a little bit here because this wasn't published in press, but this was a really nice abstract that was presented at the ERS by the Dutch group. And what they did here was they looked at 50 explants from surgical lung biopsies and autopsies and transplant explants. And they looked at the histopathology and they divided between plexiform and non-plexiform vasculopathy. So plexiform would be the typical IPAH, right? And they said, okay, well, let's look at the non-plexiforms and what do they look like? Well, the non-plexiform patients tend to be older, they tend to be male, and they tend to be smokers with a lower gas diffusion. So it seems that that phenotype, the lung phenotype, has a different form of vasculopathy. So how does that then behave in clinical practice? So this is back to 2022, and this is looking at Compera and Aspire data from Sheffield combined. And when they divided patients into classic IPAH and the lung phenotype IPAH, so that's smokers with a low DLCO, and compared them with true group 3 PH, they found, rather unfortunately, that the IPAH lung phenotype in response to therapy behaved just as if they were group 3 in terms of risk, in terms of 6-minute walk, in terms of NT-proBNP, and also in terms of mortality. So this is these groups are going to be a tough nut to crack. And if your cohorts are enriched with these patients, then don't expect your data to look as good as you might hope. So what about if you treat patients with comorbidities with initial upfront combination therapy? Back to the Italian IFNET group here, and this was published in ERJ Open. And what they found is that as you built up your number of cardiac comorbidities, your initial drop in pulmonary vascular resistance was lower with dual upfront combination therapy. And then if we just focus on the top one here, the ESC-ERS risk score, what you can see is that from baseline to follow-up here on the right, the rate of improvement in your risk score goes down. So less responsive to therapy. Nonetheless, still a response. So we shouldn't give up on these patients at all, but we may expect less of a response. But interestingly, they didn't see too much in the way of worsening side effects. Now, to finish up, this is, I'm sorry, a little bit depressing. And it's a call to arms that although we've had so much positive news in terms of new drugs coming out and new drugs being trialed, that we are not there yet. So here are some temporal trends looking at the Compira registry. What you've got on the left here is all patients, and top right is patients under the age of 65, bottom right, patients over the age of 65. And you have 10 years from 2010 through to 2019. There we are, 2010 to 2019. And you have the rates of combination therapy in dark blue versus monotherapy in light blue at 3 months and 1 year. And then no therapy, very light blue down here. What you can see, the overall trend, is that there's an increase in the use of combination therapy by 1 year, which really starts to develop in 2011, 2012, and then flattens off. Around the time of ambition, I guess. And you can see it's used more in the under 65s than the over 65s. Now, I'm not being critical about whether we're using enough combination therapy or not, because these will be mixed phenotype patients. However, over that time of increasing combination therapy, we've not really seen any change in 1 year mortality. So you've got the same thing here. All patients on the left, the younger under 65s, the older over 65s here, top and bottom. And what you can see is that there is no overall trend in terms of 1 year mortality. 3 year mortality is starting to get interesting and just about starting to get there. And there's almost a signal there. So when people say, oh, well, we're doing super well now, and when sotatercept comes along, that's it, we're done. We don't need any more drugs coming to market. Sorry, that's not true. We can't give up. We've got to keep going. We absolutely have to keep going. Because we're not seeing those really important trends come through. Now, I suspect if we went back another 10 years, we would start to see differences, okay? But we are not there by any stretch of the imagination. So how potentially could we get better in the next 10 years? As apart from developing new drugs, we need to be cleverer about new phenotypes. And Sean is going to give us a nice talk on personalized medicine tomorrow. But if we're going to personalize medicine, we need to understand diseases better. Now, we don't have a personalized medicine at the moment for these types of patients with PAH and SOC17 variants, but it's a new phenotype that we need to be looking out for. So a nice study from the French, again, showing that these patients, they tend to be 1.5 to 1 female to male, diagnosed at a younger age with these mutations, and probably about a third of them having associated congenital heart disease, ASD, VSD. And they have interesting imaging and histopathology findings, much more tortuous vessels, You can see them here, these tortuous vessels, aneurysmal vessels here, right out to the periphery, and some of these connecting up with veins, and these fissural abnormalities, an interesting histology with microhemoptysis and venular dilatation. And so, but by recognizing these phenotypes, we may start to develop individualized therapies. And there's a big news story in the UK at the moment about a one-year-old child who's just been the first child to have targeted gene therapy for some horrific neurodegenerative condition. These guys are doing it, and how long will it be before we can start doing it? So thank you very much. Here's to 2023. No questions.
So thank you, Professor Howard, for your elegant talk, and we'll have to go to the next lecture and last talk of today. So this SAPH 2023 would like to go to the to do something different from the usual. So we'd like to share with you a patient experience. So Mr. Fahad Kahtani, we are so pleasure and honored to be to ask you to come with us today. And also I would like to ask Professor Abdullah Walan, who is the primary physician who is taking care of this case. So please, Mr. Fahad and Professor Abdullah.
Thank you, Mr. Chairman. Thank you so much. Okay, thank you so much. And thanks for the two speakers. We didn't give you a chance to answer questions, Luke, but maybe. So I encourage everyone around the dinner time, if you have questions for Luke or Olivier, please go ahead. And I also encourage everybody to use this forum to interact with the PH experts, because this is your chance for the coming 2 days. Now it's my pleasure to introduce my friend and my patient, Mr. Fahad Al-Kahtani. Let me initially speak about him in English, and then he will talk in Arabic because the vast majority are actually Arabic-speaking attendees. So Fahad was referred to me initially in 2012 from my great colleague, Dr. Hazza Zahrani. You all know him. He's very expert in hematology, rare diseases, particularly antiphospholipid syndrome. Fahad used to have a primary antiphospholipid syndrome, but was really behaving badly for many years. In fact, he had many catastrophic episodes where he developed several thrombolytic diseases, but also he developed all kind of complication of antiphospholipid syndrome, namely recurrent pulmonary hemorrhage, ICU admission for respiratory distress, deep vein thrombosis, and almost all his deep venous system. And then, obviously, he received many treatments in terms of immunosuppressive therapy and many other things. But then the hematology group there decided to do for him a stem cell transplant. And at that time, 2011, it was not recognized interventional treatment protocol for antiphospholipid syndrome, but there were a few data coming up at those days. And I think Fahad was telling me today he was probably number 1 or 2 in the world who received stem cell transplant for catastrophic antiphospholipid syndrome. And alhamdulillah, that was very successful. And all these catastrophic crises that used to come to him frequently stopped. When he was stabilized and he was only on small doses of immunosuppressive therapy, obviously by that time, he started showing up the complication of his antiphospholipid syndrome, namely CTIF, chronic thromboembolic pulmonary hypertension, because throughout the course of his antiphospholipid syndrome, he had several DVTs, several PEs, and several VTEs in his deep venous system, and obviously ended up having severe chronic thromboembolic pulmonary hypertension. So the first time I saw him was 2012, and at that time we did not have the pulmonary endarterectomy surgery available at King Faisal. Of course, we did the thorough workup for him, and then we started him obviously on medical therapy at that time, and then I sent him to United States. So he received his pulmonary endarterectomy at Duke University Medical Center, and actually he came back like 6 months later with significant improvement in his hemodynamics, although he remained having some residual pulmonary hypertension. And as you all know, antiphospholipid syndrome as a cause of CTEPH, they behave differently from other causes of thrombophilia, ending up with chronic thromboembolic pulmonary hypertension in two ways. One, they do have a small vessel disease, significant small vessel disease. So all surgeries normally, even successful surgeries, still some of these patients will have some residual pulmonary hypertension. And the other way they are different, they actually progress with time, even if they have near normalization of their hemodynamics. Not necessarily all of them, obviously, but this is what we have observed in our cohort. We have about 50% of our CTEPH patients are actually primarily antiphospholipid syndrome. So after the stem cell transplant, and then a year later he received the pulmonary endarterectomy, and then his hemodynamics improved, he became a new person. And today I asked him to come to share his experience with you when he had the disease, and then of course after he had the treatment. So فهد الله يحييك، شكرا لقبول الدعوة. زملائك واخوانك الاطباء يعني يبغون يعرفون باختصار يعني معك 10 دقائق ربع ساعة تكلم عن معاناتك مع المرض في البدايات، وكيف كنت تؤدي وظائفك اليومية العادية، وبعد ما عمل لك الدكتور الزهراني زراعة نخاع العظم، وبعدها عملوا لك عملية ضغط الشرايين الرئوي وإزالة الجلطات والعلاجات، واستمرارية يعني المتابعة في المركز الملك فيصل. أعطينا قصتك باختصار. واهمها طبعا فهد، الدكاتره بيشوفون مرضى ضغط الشرايين الرئوي بانواع المختلفه، لكن يمكن ما يعني المعاناه الحقيقيه اليوميه للشخص اللي عنده ضغط الشرايين الرئوي يحتاجون يعرفونها. تفضل.
السلام عليكم. أنا فهد القحطاني، مهندس كيميائي، حاصل على درجة الماجستير من جامعة الملك سعود، مصاب بمرض الأنتيفوسفوليبيد منذ البداية. تم التشخيص في عام 1413 أو 14، جلطة جات في الفخذ الأيمن، وكانت في البدايات يعني ما في تحديد لأنه أنتيفوسفوليبيد، كانوا معتبرينه تخثر دم عادي. استمريت على الورفرين، يعني أتوقع أنه كان المرض في بداياته كانت الجلطات خفيفة. بديت حياتي الجامعية في عام 1419، وهي تعتبر يعني من وجهة نظري أقوى جلطة وأتعب جلطة جاتني 1419 وقت الاختبارات النهائية. جاتني جلطة في الفخذ وأنا عرفت أنها جلطة، بس إني قلت بكمل الاختبارات، وأتوقع أنها طلعت للرئة، وفي نفس اليوم يعني بعدها بيومين صار عندي نزيف دم وكحة دم، ورحت لأحد مستشفيات الرياض الكبيرة، وكانوا عندهم صدمة. دخلت العناية المركزة، كان أغلب الدكاترة المشرفين علي يعني متوقعين الوفاة في أقرب شيء. كنت في العناية المركزة، جلست تقريبا شهر في العناية المركزة، ومن كثر ما مو مستوعبين حالتي طلعت من العناية المركزة خروج على طول أول ما رجعت الأمور. وبعدين بديت مع مستشفى الملك خالد الجامعي، واستمريت معهم تقريبا 12 سنة، وكانت الجلطات تتكرر بس انها صارت تزيد، يعني صارت يعني تقريبا كل شهرين تجي جلطة. وكثر الجلطات يعني وانا اتكلم غير ممارسة الرياضة، وانا اتكلم لازم اوقف واخذ نفس. استمريت، كانوا يقولون لي انه ما في حل للمرض هذا، ودراسات، ورحنا لزملائنا اللي برا المملكة، حالتك انها تجيك الجلطة تتسيل الين الله يفرجها. في مرة من المرات كان البروف حقي مسافر، ومسكت حالتي البروف فرجة القحطاني، وقالت لي جسمك ما عاد يتحمل جلطات، ولازم انك تروح في دكتور في التخصص اسمه هزاع الزهراني، شغال على زراعة الخلايا الجذعية، وممكن انه العافية بعد الله عندك، لانه تجاوزت 40 جلطة بكثير الجلطات اللي مرت علي. وفعلا تواصلت الدكتورة فرجة مع دكتور هزاع، وكان في يعني قبول قوي من الدكتور هزاع، وكان الإجراء اللي بيسوى لي العلاج الكيماوي ذا كان مرة الريسك عالي، فالدكتور هزاع كان يحاول إنه يجد حل غير هذا، ولكن جات يعني بعدها بشهرين جات جلطة وإحنا لسه ما بدينا، فتكلنا على الله. وكان الدكتور حاط مجموعة من الأوراق حقت التوقيع إنه الحالة والعملية وزي كذا، فأنا كنت أمر توقيع سريع، يقول لي اطلع على الأوراق ترى المخاطر عالية جدا. قلت اللي يلا كاتبه بيجي.
هذا عشان
زراعة الخلايا الجذعية، صحيح. والكيماوي اللي هو قبل الخلايا الجذعية. قلت اللي الله كاتبه بيصير، يعني لو الله كاتب وفاة يعني باليوم الفلاني وأنا عييت ما أوقع الورقة وطلعت، يعني بتعدي الوفاة، هي كذا كذا. والحمد لله سويت زراعة الخلايا الجذعية، كانت متعبة جدا جدا. دخلت غيبوبة تقريبا 8 أيام، وبعدين جلست في العناية المركزة شهرين، التنويم العادي شهر، والحمد لله عدت. يعني كانت الزراعة في 11/11/2012، وكان عام 2013 متعب جدا اللي بعد العلاج الكيماوي والزراعة، والحمد لله عدت. وصلنا في 2014 حولني الدكتور هزاع الزهراني للدكتور عبد الله الضلعان، ودرس الحالة من كل النواحي، وأشعة وتحاليل واختبارات، وقرر أنه لازم أنك تسوي عملية تنظيف الشريان الرئوي أو المصطلح حقه. وقال يعني لا، يعني بنطلعك المستشفى دوك في أمريكا تسويها هناك، أريح لك، وفي مراكز تأهيل متخصصة هناك بعد العملية. وفعلا أنا كنت رايح يعني فعلا متعب، وكان أخوي المرافق معي، والمشي تعبان، وطلعت من العناية المركزة، وجلست 7 أيام من بديت العملية إلين طلعت من المستشفى، 7 أيام بالضبط. وطلعت 3 أيام ريحت، وبديت في التأهيل مدة شهرين. وبعدين رجعت تقريبا على نهاية 2014، وكان الاختلاف 100%. يعني رجعت لو بطلع 10 أدوار كان الوضع عادي، رجعت لياقتي طبيعية جدا جدا، وصرت أمارس حياتي طبيعيا. وصرت مع الدكتور عبد الله تقريبا مراجعات من بين 3 أشهر 4 أشهر، اختبار 6 مينت، والتحاليل العادية والأشياء الروتينية، واللهم لك الحمد. يعني فرق 180 درجة. أنا كنت حتى عيالي الصغار أنا أقول للدكتور عبد الله، أنا يعني ما تعاملت معهم إلا واحد في 6 ابتدائي وواحد في 4 ابتدائي. كانت حياتي كلها اللي قبل من انولدوا إلين هذا، وأنا من المستشفى إلى البيت تعبان. المستشفى ما أقدر ألعب معاهم، ما أقدر أمارس حياتي الطبيعية أني أستانس معهم. بعد ما رجعت من أمريكا اللهم لك الحمد استمتعت بحياتي كل المتعة. وصلت دراستي الجامعية، أنا كنت حاصل على البكالوريوس، صح أني يعني أطول طالب خلص البكالوريوس اللي هو الهندسة الكيميائية، مع أني كنت أحذف أترام، وكانت الجامعة مقدرة الوضع حقي. تخرجت الحمد لله ممتاز مع مرتبة الشرف. وبعدين بعد ما رجعت من أمريكا انقبلت ماجستير ودرست ماجستير، وانقبلت بعدها دكتوراه، وبديت تقريبا ترم أو ترمين، ولكن صار في ظرف طارئ وانسحبت من الدراسة. ولكن كل شيء بظروفه، والحمد لله الصحة طيبة، الاستمرارية على المواعيد وعلى الأدوية اللي مصروفها لي من الدكتور عبد الله والأطباء اللي في مستشفى الملك فيصل التخصصي. وهذه تقريبا مجمل الحال.
شكرا فهد شكرا لقبولك الدعوة وأنك تشارك قصتك مع الزملاء، لأنه الأطباء هم بيجيهم المريض ويعملون التشخيص ويعملون القسطرة وإلى آخره ويبدو المريض على علاج، بس حنا حبينا اليوم أنهم يسمعون منك مباشرة. بعضهم طبعا لسه بادين في تخصص الصدرية وإلى آخره، منك مباشرة معاناتك مع ضغط الشريان الرئوي. أنت قلت كلمة يعني تهز الوجدان بشكل أو بآخر. أنت قلت أنه أولادك من انولدوا إلى صاروا ب10 سنوات ما كنت تعرفهم، كنت من مستشفى للبيت، من البيت للمستشفى. بعد ما تعالجت الحمد لله وكانك تبدأ حياة جديدة معهم، كانك تعرفهم من جديد إلى آخره، كنت تتكلم وتوقف عشان عندك ضيق نفس، والحمد لله. تفضل.
اللي بقولها نقطة واحدة، إنه 90% أو يعني في هالحدود من العلاج نفسي. 90% أو بهذه النسبة من العلاج مو بأدوية ومو بعمليات، الدعوة على نفسية الشخص وتعامله مع المرض. ويعني أنا كنت أتعب وأدخل المستشفى أيام الجلطات والكيماوي اللي كانوا، والله العظيم إنه يوم زراعة الخلايا الجذعية إنه يعني كان الدكتور المكان اللي ذا لو ترمي إبرة ما نزلت من الأطباء التخدير وكل الناس. وجاني دكتور وقال لي لأنه بيصير تخدير كامل، قال لي اتشهد ما ندري وش بيصير. أنا يعني داخليا مؤمن إني برجع تعدي العملية وبمشي. فأذكر إني قلتها بهالشيء، أنا عندي مشكلة أكبر من المرض بتعرفونها. قلت أنا أشهد أن لا إله إلا الله وأشهد أن محمد رسول الله. كان هذيك الليلة في مباراة للنصر، قلت والله يجعل النصر يفوز. الدكتور قال لي ما فيك طب.
أجل أنا أبغى أقوم.
أنا أتوقع أن الشيء النفسي هو أكبر داعم، وأنا سمعتها من كثير من الأطباء اللي مريت معاهم، إنه نفسية المريض يعني هي اللي تدعمه مع الأدوية ومع هذا، بس إنه شيء حفاز للإنسان.
الحمد لله. So يعني باختصار invest in your patient. You can actually make a great change in the life of a person. And Fahad is a classical example of this. Anybody has any question to Fahad من الأودينس؟
صرت أقدر أحضر مباريات.
الحمد لله. Anybody? نوال تفضلي.
Thank you. وشكرا يا أستاذ فهد. إحنا فكرتنا كانت في الساينتفك كوميتي إنه إحنا نجيب شخص يعاني من المرض، لأنه نبغى نبين فكرة إنه this is what we are doing for. هذا هو الشيء اللي إحنا يجعلنا نقيم هذه المؤتمرات وسنة بعد سنة، ونحاول إن إحنا نوصل للأدوية المثالية اللي تساعدكم. فشكرا لحضورك وإفادتك. نبغى منك كلمة للمرضى اللي بيتخوفوا من المضاعفات الجانبية للأدوية، وأنت تعرف أنه أدويتنا أكيد كلموك الدكاترة تأتي بمنافعها وبمضاعفاتها الجانبية. تحمسهم، تقول لهم على الفوائد اللي أنت حصلت عليه منها، مسيلات الدم، أهمية الالتزام على مسيلات الدم. شكرا لك وشكرا لطبيبك دكتور الضلعان. شكرا.
أنا أكثر واحد أحب أقابل مرضى، وبالغالب كل اللي أقابلهم يحسبون أني أنا ماني مريض، أنا طبيب، عرفت؟ وأنا أحب أعلمهم أنه كل شيء مقدر ومكتوب مع الالتزام بالأدوية. أنا أقول للمرضى اللي متخوفين من العلاج أو من العمليات أو من الإجراءات اللي يقررونها الأطباء اللي هم أعلم منه، أنا أقول إنه عشان ترجع لحياتك طبيعية وتستمتع بحياتك الطبيعية وتعيش إنسان طبيعي، لازم انك تنضبط على ادويتك. انا دائما اقول النفسيه، ولكن الانضباط على الادويه، واصلا كل شيء له مضار. حتى حبه البنادول لو تاخذها ممكن يصير لها يعني مضار على الجسم، ولكن اذا استمريت بدون دواء، بدون ادويه، بدون علاج سواء كان كيماوي او اي شيء اخف او تاهيل، هي فتره انت يعني يكون داخليك انه انا ببدا العلاج، ويعني الدكتور الخطه العلاجيه يعني 2-3 ويكون داخليا متاكد انه بعد 2-3 راح يرجع للحياه الطبيعيه، راح يستمتع بحياته الطبيعيه. واهمال الادويه انا اتوقع انه اكبر خطا، واتوقع انه من الاشياء اللي ممكن تتحاسب عليها.
احنا بصدد ان شاء الله، شكرا فهد، بصدد اليوم الاخ حسين، دكتور حسين اقترح علينا واحنا كنا نناقشها هذه ونحتاج مساعدتكم فيها، بعمل patient pulmonary hypertension patient association، ونبغى نعطي فهد الليد ان ذس، لانه اوبسلي ان شاء الله قادر انه يساعد يعني اخوانها المرضى في هالموضوع. فهذه يعني ان شاء الله تعالى من المهام اللي راح نكلفك فيها فهد والزملاء معاك في الجمعيه ساف ان شاء الله تعالى. أنا شاكر ومقدر لك وشاكر ومقدر لحضوركم. Thank you everybody for sticking to the last minute, and this is the conclusion of our evening session. The dinner will be served in the hall where the workshop was, and thank you all, and we'll see you in the morning inshallah ta'ala sharply at 9 a.m. Thank you so much. شكرا فهد، نروح نتعشى. Sorry, correction, it's 8:20. So the morning session will start at 8:20.